Είμαι γηρίατρος. Είμαι στο Ηνωμένο Βασίλειο από το 2013, σπούδασα στην Ιταλία, στο Πανεπιστήμιο της Μπολόνιας, έκανα την ειδικότητά μου στο Πανεπιστήμιο της Βερόνας. Το 2010 τέλειωσα το διδακτορικό μου στα Genetic of Healthy Aging, ένα ευρωπαϊκό πρόγραμμα έρευνας με τον καθηγητή Κλάουντιο Φραντσέσκι, πάλι στο Πανεπιστήμιο της Μπολόνιας. Το 2013 μεταφέρθηκα στο Ηνωμένο Βασίλειο, στο Πανεπιστημιακό Νοσοκομείο του Μίλτον Κίνς. Έχουμε ειδικευόμενους από την Οξφόρδη και εδώ και 7 χρόνια έχουμε και την πρώτη ιδιωτική ιατρική σχολή από το Πανεπιστήμιο του Μπάκιγχαμ. Οι πρώτοι μας φοιτητές πήραν το πτυχίο τους πριν από 2 χρόνια και έχουν ξεκινήσει πλέον την καριέρα τους ως γιατροί. Δυστυχώς τα ελληνικά μου είναι λίγο φτωχά στην ορολογία, οπότε θα μου επιτρέψετε να τα πω στα αγγλικά που τα κατέχω λίγο καλύτερα. Αυτή εδώ είναι ένα projection του τι θα γίνει το 2050 και όπως βλέπετε οι ηλικιωμένοι άνω των 65, αν θεωρούμε ηλικιωμένους τους άνω των 65, για την Ελλάδα και για την Κεντρική Ευρώπη θα είναι από 28% ή περισσότεροι, οπότε γερνάμε και γερνάμε και πάρα πολύ γρήγορα. Αυτή η slide η διαφάνεια δείχνει ότι το 2050 θα είμαστε γύρω στα 2 δισεκατομμύρια με ανθρώπους άνω των 65, εκ των οποίων τα 500 εκατομμύρια ανά τον κόσμο θα είναι 80 και παραπάνω. Τα hip fractures στο Ηνωμένο Βασίλειο είναι γύρω στα 76.000 και το βλέπουμε να ανεβαίνουν κάθε χρόνο. Για την ώρα μιλάμε για ένα έξοδο του health system γύρω στο 1 δισεκατομμύριο λίρες και αυτή η κατάσταση δημιουργεί ένα κόστος για το NHS, για το Εθνικό Σύστημα Υγείας, γύρω στο 1% του όλου budget. Το ξέρουμε πολύ καλά, οι hip fracture patients είναι usually frail, dependent, with pre-existing medical problems. They have post-operative complications and increased post-operative mortality. Το 2007 η British Orthopedic Association μαζί με το Royal College of Physicians, το Royal College of Anesthetists και το British Geriatric Society published the Blue Book, the known Blue Book, for the care of patients with fragility fractures. It identified 8 aspects of good care and this prompt admission under the care of an orthopedic consultant, rapid comprehensive assessment with surgical, medical and anesthetic input, minimal delay to surgery, well-performed surgery, prompt mobilization, early multidisciplinary rehabilitation, early supported discharge and community rehabilitation, and secondary preventions of fractures. The best practice tariff started from 2010, following the publication from the National Confidential Inquiry into Patients' Outcome and Death that showed that the poor quality of care was being given to elderly patients undergoing hip surgery. So they included in the best practice tariff system scheme with the hip fractures with a proposal to improve and universalize the care. The main let's say the basic of the best practice tariff is that there is a standard payment for the hospital of 450 pounds roughly for the patients that they are coming for whatever pathology in the hospital. If you achieve and you tick all the boxes that the best practice tariff requires, you are going to have around 1,300, 1,400 pounds for each patient, which is lots more of the basic payment. The fundamental principles of femoral fractures are surgery, possibly within 36 hours, and the orthogeriatric assessment within 72 hours from admission and orthogeriatric care. Από τον Απρίλιο του 2020, they add the periprosthetic and long femoral shaft fractures in the best practice tariff scheme. Γιατί θέλουμε τον ορθογυρίατρο. Θα αναφερθώ λίγο στο frailty, αν και πολλοί ομιλητές μιλήσανε, για να εξηγήσω γιατί ο ορθογυρίατρος είναι σημαντικός. Πολλοί πιστεύουν ότι η frailty είναι disability ή είναι comorbidity. Μέχρι το 2013 το τι ξέραν οι γηρίατροι να ορίσουν δεν ήταν απαραίτητα αυτό που οι γύρω μας λέγανε ως frailty. Ας ξεκινήσουμε τι είναι το aging. Είναι ένα lifelong accumulation of molecular and cellular damage caused by multiple mechanisms under the regulation of a complex maintenance and repair network. Αυτή είναι ο ορισμός από τον Kirkwood, ένας γηρίατρος και γεροντολόγος του Newcastle, που τον έφτιαξε αυτόν τον ορισμό το 2005. Όταν τα συστήματα δεν δουλεύουν σωστά, έχουμε τα geriatric syndromes που περιλαμβάνουν την functional decline, incontinence, dementia and delirium, with falls and the fragility fractures that we know very well. What is the definition of the physical frailty? It's a medical syndrome with multiple causes and contributors that is characterized by diminished strength, endurance, and reduced physiologic function that increases an individual's vulnerability for developing increased dependency and or death. Αυτός είναι ο ορισμός από το International Geriatric Society και έγινε published το 2013 τον Ιούνιο στο Frailty Consensus Call to Action. The prevalence of frailty, the overall psychosocial and physical is 10.7%, of which 9.9% is physical frailty, and it is higher in women than in men. This proves why disability and comorbidity does not always correspond with frailty. So disability, if we think the Paralympic champions, not all the disabled people are frail. If we think also around our families, our older relatives, that they might have some hypertension, some problems with their heart, but they are still independent, not necessarily a comorbidity corresponds to frailty. And there are people that they are frail without having lots of comorbidities. Of course, the three conditions can overlap, and they are overlapping only for a 20%, 21.5% in this study. There are some screening tools, and we need to advocate for screening for frailty for all persons aged 70 years old and above, or any person with significant weight loss. I'm not going to discuss anything apart of the these tools, apart of the clinical frailty scale. This is for me one of the most important tools that we have. We are using it from 2015. I advocated the use of this in my hospital with the hip fracture patients. Reason is because you don't need to make the patient walk around, and it is easy to classify a patient that comes through the front door, depending on just reading what is the explanation of each stage. The second is that this includes the symptoms for mild dementia, moderate dementia, and severe dementia, and they are classified accordingly to mildly frail, moderately frail, and severely frail based on the level of dementia they have. The problem with the hip fracture starts if a person is mildly frail or moderately and of course severely frail. These are the categories that they will have much more difficulty to recover, and they will need the prolonged rehabilitation. Another useful part of this scale, it is that explains very well and what is a person's frailty stage, and we can speak with the relatives and their carers of why somebody will not recover as much as we would expect after a femoral fracture. So what is happening with the frailty? Actually, it is a vicious cycle that once has been established is difficult to cut off. And if we start from here, low physical activity, because the person is a little bit older, they will eat a little bit less, they will have some degree of sarcopenia with reduced strength and power and exercise tolerance reduced and towards to the exhaustion, and they will have slow walking speed. And this will carry on this vicious circle will carry on and carry on. But the frailty is a phenotype. What is happening inside the body? So it depends on the genetics, first of all, and of course of the immune system. If we are lucky to have pro-inflammatory agents in our early life, we will have a high resistance to infectious diseases with early life survival that However, when we will become older, that will put our immune system towards a more an inflammation status and inflammaging, and we will have unsuccessful aging. While if we have more anti-inflammatory agents in a younger age, we will have susceptibility to infectious diseases, but this will create an anti-inflammaging, but will give us a longevity and late life survival. So in the immune system, what is happening with the frailty? With the risk factors that they are the aging, the genetics, our lifestyle, the diseases we are suffering, and the environment, we will have a degree of chronic inflammation. This chronic inflammation will go to the intermediary systems, especially the musculoskeletal, and will give weakness, weight loss, exhaustion, low activity, and slowed performance that we know it is the frailty phenotype. And as consequences, we will have the falls, the disability, the dependency, and death. This slide shows very well what happens if you see 6 different systems of the body: the hematological, inflammatory, hormonal, adiposity, neuromuscular, and micronutrients. More the systems are failing, more the prevalence of frailty. So the frailty is an outcome of depletion or dysregulation of a complex system. The frail skeletal muscle is often correlated with 2 other major geriatric syndromes, the sarcopenia and the cachexia. Like this lady is definitely sarcopenic and possibly cachectic. The sarcopenia, this slide illustrates how an older person can be sarcopenic independently if they are active or not. This is a CT from a slide, a transversal slide of a young 40 years old gentleman of the thighs, and this red dotted determine where is the muscle of the thigh. If you see how much it is reduced, this is the same red dotted line. Here we have muscles with adipose tissue infiltration, and this is the same level of transversal CT in an 80 years old man. Of course, frailty goes into the bones and gives osteopenia and osteoporosis. The most important for me, it's not the sarcopenia and the osteopenia, but it is also the changes in the posture. This is supposed to be a 75 years old. Now we see these changes in the skeletal, in the skeleton in older people. But the most important thing is that the center of the gravity of this, of the weight of this person is beyond their feet. It is very easy for these people to fall because, of course, they are more easily to lose their balance. And also, if you see the changes of the spine, the curvature and the kyphosis determine that the pelvis and the ribs are much closer, they will have problems on breathing. And these people, especially after a hip fracture, that they will not breathe very deeply to not be in much pain, they will develop chest infections because the anaerobes here are going to have a party. So what happens with the frailty, if you have a minor illness and you are not frail and you are quite independent, a couple of days of antibiotics and you go back to your normal activity level. If you are closer to be dependent, if you have a similar minor illness, it will take much longer to recover and probably you will not go back to your previous status of function. And if we are already frail, imagine with a fall having a hip fracture that will give delirium inside the hospital, will give the fluctuating disability, and at the end, it will increase the care needs and it will give admission to long-term care. What are the potential interventions of frailty? It is the exercise, the nutritional intervention, especially for me, the vitamin integration when they are in the hospital, my patients, and the reduction of polypharmacy. A special mention on the functions of vitamin D. I'm not talking about the effect on the bone. It's not the place for me to talk. Many other people have discussed that in this event, but it is especially for the immunomodulation and the cell growth and differentiation that the vitamin D does. And that's why I always give high levels of high dosage of vitamin D if the patients that they are coming through the front door, they are depleted on vitamin D. This is a snapshot of, we present this in the European Congress of Trauma and Emergency Surgery in 2017. People with that they are admitted in between May and July in 2016 in our hospital. You can see on admission the definition of frailty with the clinical frailty scale, and on discharge there is a dramatic reduction of the percentage of the people that they were well and managing well, and a dramatic increase of the severely frail following a hip operation. The severely frail, the very severely frail and terminally ill, they have increased, and I have to say the 7.7% corresponding to the mortality percentage that we had in the 30 days post-admission. What the orthogeriatrician is doing, we are ensuring that the patient receives the highest standards of geriatric care. We have knowledge and expertise on age-related changes. We provide holistic and tailored to the patient care. We complete the fall risk assessment, and in case the fall is for a medical reason such as syncope, we plan for the relative investigations and treatment. We complete the bone health assessment, and we are starting the osteoporosis treatment immediately. We don't wait for a DEXA. If someone has a fall from their own height, it is already a fragility fracture. We review regularly the patient and treat the clinical complications that they might present, and we coordinate the multidisciplinary team meeting and discharge plan. When I joined in 2013, it was the end of 2013, so I showed that to the executive board of my hospital to prove that the orthogeriatrician has a major effect in the care and the discharge destination of the patient. The majority of the patient, after I started working in the hospital, I was then the only orthogeriatrician, and I advocated for the second person to come through, and at the end they came 3 years after 2014. It is that the majority of the patients are going to their home, less in rehabilitation unit, and this is because we work very, very closely with the physiotherapist. So the majority of the physiotherapy interventions, they were inside the hospital, and this is something to show and to be very proud of, at least I was, because the patients were not going back to the acute hospital, they were not going back to medical wards, they were staying under my care in the orthopedic ward. The nurses have developed fantastic skills, and they were very well trained with a common effort from myself and all the team, and they were treated inside the orthopedic ward, and they were keep on having their rehabilitation. What happens in the patients during my hospital, Milton Keynes University Hospital? The patient is identified as hip fracture and admitted in the orthopedic unit. The femoral nerve block is performed by A&E or trauma and orthopedic doctors. And the trauma and orthopedic doctor who receives the patient prescribes also the neck-of-femur fracture care bundle with particular attention and analgesia, laxatives, and the preload that it is a high carbohydrate beverage that we give to the patient 12 hours before surgery and 2 hours before surgery to help with the starving before the surgery, and it has shown that has given better outcomes to the patient. We try to make them be assessed by the physiotherapist possibly within 24 hours and to start physiotherapy within 24 hours from surgery, including the weekends, within 72 hours, possibly in the same morning following the admission or after the admission, to be seen by the orthogeriatrician. And if they are stable and they can go to surgery, to be operated within 36 hours of admission. From when COVID started, some changes happen in my hospital. So we have a daily board round. We used to do the board rounds, only the geriatrician and the rest of the team. But from April also the trauma and orthopedic doctors are there, the physiotherapist, the occupational therapist, the nurses, and the discharge coordinator. The orthogeriatrician is chairing the weekly multidisciplinary team meeting where we discuss the progression of the patient in physiotherapy, their nutritional status using the MAST score, and if they need the dietitian to intervene, the medical and nursing issues such as if they open the bowels, if they still have a catheter, if they have pressure ulcers, and what will be the discharge planning. This is a snapshot of my hospital from 2012 until now. This is from the National Health Fracture Database. As you see, the majority of where we were failing with the best practice tariff is the time to surgery. Sometimes happens, we cannot operate everybody for various reasons. And these other colored dots are with the new things that the NHFD for the best practice tariff is asking. The other thing that I would like to show you is from 2017 that the NHFD start to count also the mortality. Our mortality rate in 30 days before after surgery. The gray line is the national average. Our hospital is the black dotted and continuous line. 2019, I'm happy to say that we are down to 5%. Και αυτά είναι από μένα. Σας ευχαριστώ πολύ. Και όποιος θέλει, αν θέλετε να επικοινωνήσετε, αυτό είναι το email μου.